Hello, everyone. Thanks for joining us for this Part B Otolaryngology Common Rejections and Denials webinar. This webinar is designed for those who submit claims on the CMS 1500 claim form or the 837P electronic claim. My name is Mary Mucko. I'm a specialist on the Provider Outreach and Education team at WPS GHA. I will be your host today, and assisting me is my friend and colleague, Ellen Vera. We include this disclaimer in all of our education, and we do so to remind learners that although we made every effort to provide current information, the information is subject to change. It is on the CMS website where you will find the Medicare rules that determine final coverage. These laws, regulations, and rulings will always prevail. We will provide responses to questions based on the facts given. And as a final reminder, CMS prohibits recording of this presentation for profit-making purposes. Remember that we're recording this event, so you'll be able to refer back to it at a later time. Here is our agenda for today, and this really reflects only the items that I plan to present now during this 60-minute education event. We ask all of our learners to carefully read our advertisements because this really reinforces what specifically we intend to provide during our webinar. Today's topics, as I advertise, would be specific to Part B Specialty 04 providers. That's otolaryngology providers who submit claims on the CMS 1500 or the 837P professional claim. I will provide details on common rejections and denials, and this includes what is a rejection and a denial. I'm going to talk today about how you can fix or avoid these rejections and denials. And then I'll also be providing resources. And in the time remaining, I will answer your questions that are related to these topics that I plan to present today. Now, to fully understand rejections and denials, it really is important to recognize the path that a claim takes, or what we like to call the life of a claim. This is a simplified graphic on how a claim gets into our system. Of course, the provider would provide the service, submit the claim. The system may reject that claim, and when it does so, a 277 or 999 report is generated. This is for batch rejections that I'm talking about. A claim is submitted electronically to Medicare, and a 999 report will confirm claim receipt. We also generate a 277 report, and that report provides more specific information. In that 277 report, we'll clarify and supplement and provide additional information regarding the data content requirements for the claim. And then it will let you know that you need to correct or resubmit that claim. In order to read these documents, our electronic data interchange staff has created a companion guide that will help you understand the information in those reports. This is a simplified graphic that shows what happens to a claim that does get moved into our system, but Medicare deems it as unprocessable. In that case, the provider would provide the service, submit the claim, but something is illogical, doesn't make sense, in an incorrect format, and the written remittance advice that generates would inform the provider that we are rejecting the claim. Here is a slide that shows the difference between a rejection and a denial, and it's really important for people to understand that these are very different things. I think sometimes even when I'm talking to people at WPS GHA, we use these terms interchangeably, and we really shouldn't, because they are truly two very, very different things. On the left side of this slide, you will see a rejection is what we, or CMS, actually calls unprocessable. It's returned on the front end. It's never actually adjudicated. The reason why it's rejected is that there's something illogical or incorrect or something missing on that claim, so we can't process it. There are no appeal rights. What you need to do is resubmit the claim. And for these rejected claims on the remittance advice, you will see an MA130 remittance advice remark code or a C0 or a CO rather 16 code or group code on that remittance advice. And I'm going to talk about those codes in just a minute. A patient is not liable for a rejected claim because it's not adjudicated. A denied claim, on the other hand, is adjudicated. It's denied because it fails to meet payment criteria. Perhaps the entire claim denies, or it could be a claim line. Reasons for claim denial are listed here on the slide on the right-hand column. There could be a statutory requirement that doesn't allow us to make payment for a particular service. Maybe the service or the line item denied due to medical necessity, and frequency is a type of medical necessity denial. And there's also reasons why a claim fails to meet payment criteria that are due to eligibility. Could be eligibility for the patient or the beneficiary, or it could be eligibility as it pertains to the provider. In a case of a claim denial, you will see the MA01 code on the remittance advice, and that code actually provides appeal rights. So unlike a rejected or unprocessable claim where there's no appeal rights, a denied claim, typically with few exceptions, does have appeal rights. And then, of course, patient liability for a denied claim is determined. The remittance advice will also note that information. So for a process claim, this graphic shows the path. The service is provided, the claim is submitted to Medicare, the claim is either paid or denied, or claim line would be denied, and a remittance advice is generated. I want to talk a little bit more excuse me, about the importance of the remittance advice. Sometimes you might hear us call this a remittance notice, or sometimes we'll shorten it up a bit and call it the RA. Most providers receive an electronic remittance advice, an ERA, as opposed to a standard paper remittance or SPR. Depending on how the claim is processed, the remittance advice could include information about any adjustments that is made to the claim or the denials. It could also include information that is missing or information about what's missing, and sometimes it even provides notice about refunds or offsets. The ERA provides payment information about the transfer of funds and payment processing from one health plan to a healthcare provider's bank, or the explanation of benefits or remittance advice. Now, when you're looking at the remittance advice or the RA, there are codes that you will see, and these codes provide information about the claim. Claim adjustment reason codes, we call those CARCs, explain why a claim paid differently than it was billed. Remittance advice remark codes, or RARCs, provide more details about the adjustment described by the claim adjustment reason code. Another type of code that appears on the remittance advice is a group code, and these convey the financial responsibility for any unpaid portion of the claim balance. You can see here on this slide that a CO is contractual obligation. This means that the provider is liable. And a PR group code means patient responsibility, or that the patient is financially responsible. I mentioned a little bit earlier that a CO16 appears on a rejected claim or an unprocessable claim. That means the provider is liable for the service, and of course the expectation is that the provider would fix what's wrong and resubmit that claim. Now you can find these code lists for RARCs and CARCs and group codes on the Washington Publishing Company's website. This is the company that maintains those codes for CMS. I've included some links here on this slide for you so you can easily navigate to the Washington Publishing Company website to find those code lists, whether they are RARCs or CARCs or group codes. Now, I do want to mention to you that we do understand that some of the codes that generate and print on the remittance advice may be a little cryptic or really may seem a bit out of date. For example, some of the code messages may include an outdated acronym. WPS can't fix that. It is this company, the Washington Publishing Company, that is that maintains those codes for CMS that is responsible for doing so. So we do get some comments from time to time. This seems a little cryptic. Can you change the message, or this is an outdated acronym, why do you continue using it? And we really don't have any control over that, other than we can communicate to CMS or to the Washington Publishing Company that it's been suggested that they consider changing that. But WPS really can't do that. So there are potential actions to choose, and you'll need to choose your action depending on whether the claim is rejected or whether it's denied. So for an unprocessable or rejected claim, what you're going to need to do is fix the error and resubmit the claim to Medicare. On the other hand, if the claim or a claim line denied, there could be multiple actions to choose from. You may be able to simply resubmit the service. You could also consider using the clerical error reopening or CER process for clerical errors, and CMS defines these as minor errors or omissions, those that are human or mechanical errors on the part of the party or the contractor. And I'll talk more about that process a bit later in this webinar. Another action to consider is an appeal. The remittance advice will provide those appeal rights, and I'll talk about appeals also just a little bit later in this webinar. Registered users of our transactional portal can render a clerical error reopening, or they can use the transactional portal to request an appeal. Remember that these self-service tools really do offer the most efficiencies to get those jobs done or to begin the appeal process. Our portal user manual provides illustrations and step-by-step instructions on how to use those portal features. If you are seeking additional information about the remittance advice or you want to learn more about it, I've included some links here on this slide to get you to more information about the remittance advice or the RA. Both of these appear on the CMS website. Next, I want to talk about whether you need to correct or appeal the MAC's decision to pay or deny a claim. I talked a bit earlier about the clerical error reopening process, and I told you that I would provide some more details later. This is that process to correct human or mechanical errors. Those are those minor errors. They're limited to errors in form and content. The resource on this slide is how to request a clerical error reopening, and this is actually a resource that appears on our website, and it provides examples of what is an acceptable or an unacceptable situation for clerical error reopenings. I can give you some examples. Let's talk about acceptable clerical error submissions. These would be mathematical or computational mistakes, perhaps a transposed procedure or diagnostic code, maybe inaccurate claim data entry, misapplication of a fee schedule, or maybe a computer error. Now, there are those situations, however, that cannot be processed as a clerical error reopening. They are also included on that resource. You can use the portal for self-service, or you can request a clerical error reopening by telephone or fax. The portal user manual provides those instructions, as I mentioned earlier. For claim denials, most often, there's few exceptions, you can request an appeal. The purpose of the appeals process is to ensure the correct adjudication of claims. And physicians, suppliers, and beneficiaries all have the right to appeal claim determinations that are made by the MAC. And the MAC, for those that might not know, is the Medicare Administrative Contractor, and WPS GHA is the MAC for Jurisdiction 5 and Jurisdiction 8 providers. The beneficiary or their representative may request an appeal on any service processed for them, but providers and suppliers may appeal services for which they accepted assignment. However, for those unassigned claims, providers and suppliers can act as the beneficiary's representative, but the beneficiary in that case would need to sign an authorization statement, let me try that one more time. An authorization statement may be one such as the CMS 1696 form. This is the appointment of representative. It's the CMS 1696. In addition, providers and suppliers may request a redetermination on an unassigned claim if Medicare denied the service as not reasonable and necessary, or in those situations where the provider or supplier billed in excess of the limiting charge. And in those cases, of course, the provider or the supplier must refund any of those fees collected from the beneficiary over and above the limiting charge. Now, the first of 5 levels of an appeal is the redetermination, and the redetermination is the only level of appeal that's rendered by a Medicare Administrative Contractor. Each of those 5 levels of appeal have time limits to file the request. There are time limits for completion that also apply. And additionally, for level 3 and level 5, you can see this is the level 3 is the administrative law judge hearing. Level 5 is the federal court review. That's levels of appeals. For those, there is an amount in controversy that applies. It's a threshold that applies, a dollar amount that applies that you need to reach before you can request those level of an appeal. But you can combine like denials on more than one claim to reach that amount in controversy. And here are a couple of appeals resources that I've included for you. The first is How to Appeal a Claim Determination. This is a resource on the WPS-GHA website. Remember, the first level of appeal is a redetermination, so you need to come to WPS-GHA first. That's the first level of appeal. So that resource provides a lot of great information, what you need to send, how to send it, where to send it, what's the address. You know, it makes reference to the fact that this is, you can use the transactional portal in order to request an appeal, or there are other methods to submit that appeal request as well. The second bulleted item there, and it's a flow chart that is updated annually, is one of my personal favorite go-tos, if you will, when I'm talking about appeals. This is the fee-for-service appeals process flow chart, and like I said, it's updated annually. So come January, make sure that you're looking at the current version, or that CMS has indeed gone out and updated this flow chart. This flow chart shows all 5 levels of appeal. It has all of the time frames on it, you know, the time frame for requesting that level of appeal, how long does it have to, or, you know, what is the time frame for completing the determination or the decision on that particular level of appeal. It has the amounts of controversy and so on and so forth. So it's just a really great resource to quickly look at and find your way. It's a flow chart. I like the way it's laid out, and I like to share that resource with my audiences. All right, now if you look back to that advertisement I talked about earlier, I said that I was going to talk about rejections and denials and how to fix them, how to avoid them, and provide for you those most common or common rejections for specialty 04 claims. So this begins then that discussion of that actual data that we mined or that we looked at. The data that I'm sharing today is all Specialty 04 submitted claims for Jurisdiction 5 and Jurisdiction 8. So that means collectively the states of Iowa, Kansas, Missouri, Nebraska, Indiana, and Michigan. While the dashboard does allow us to drill down by a specific state or states and even counties, I pulled data that I want to present to you for our entire jurisdiction of 5 and 8. For those of you that are wondering what Specialty 04 is, it's a code that's assigned to a WPS GHA provider when they enroll. During enrollment, providers self-designate their specialty. While a provider can designate a secondary specialty, it is only that primary specialty, the one designated during enrollment, that is used during initial claim processing. There are some situations where a provider will request an appeal and stipulate their secondary specialty in order for Medicare to make payment. Specialty code 04 is Otolaryngology. I pull data for claim submission dates September 1, 2023 through February 29 of 2024. The data was last refreshed on March 13 of 2024. So any claims submitted for this date range after March 13 are not included in the data that I'm presenting to you during this webinar. Here then are the common rejections by reason, and remember these reasons print out on that remittance advice for WPS Specialty 04 claims for those parameters that I identified. The most common rejection by reason is that the claim lacks information needed for adjudication. And this typically would mean you would look to other information provided on that remittance advice, or when you're looking at the claim details in the transactional portal, you would look for additional information to help you identify what it is that the claim lacks so that we can adjudicate the claim. Remember, these are rejections. They've never been adjudicated. This means you need to fix it and resubmit it. Remember, I mentioned to you that sometimes those claim reasons may be a little cryptic or out of date. This one kind of makes me smile, as does the fourth one listed here on this slide. When you receive your remittance advice for this rejection, and rejections are very different from denials, this is what it says: denied, invalid, or missing modifier. This is a rejected claim. However, that reason code that prints out on the RA says denied, invalid, or missing modifier. So this one, of course, you would look to those modifier fact sheets out on our website. Determine, is there a modifier needed, or did you put one on there that really is invalid for that particular situation? The next reason for rejection is the claim must be submitted to RRB. That's how it prints out on the remittance advice. RRB is the Railroad Retirement Board, and this is one of those situations where the claim was submitted to WPS GHA when it should have been submitted to Palmetto GBA. They are the Railroad Retirement Medicare Administrative Contractor. The next common rejection is denied, rendering, again, denied. Rendering physician number is invalid or missing. Submit a new claim. Those numbers, I neglected to tell you, to the right of the reasons represents the number of rejections for that data pull that I looked at. Next, missing, incomplete, or invalid ordering primary identifier, 99 claims. I'm going to be providing some resources for you in just a little bit to help you avoid these common rejections in the future. If you look to this slide, you'll see more common rejections: missing, incomplete, invalid name, strength, or dosage of drug, 89 claims. This is in those situations most often where you're billing for an enlisted drug or biological. Guidelines say that you need to include the name of the drug, the total dosage plus the strength of the dosage if appropriate, and the method of administration in item 19 of your claim form. And I'll provide that resource for you in just a bit. The next common rejection is the clinic number is missing or was not entered. 72, excuse me. Next, again, there's that word denial when this is really a rejected claim we're talking about. Field 11 of HCFA 1500 must be completed. This is a situation when you're looking at the claim form instructions that if there is no insurance that's primary to Medicare, you need to enter the word none on the claim form. And here again is another example of a situation where the code that's being used includes an acronym that's outdated. The HCFA 1500 is now the CMS 1500. The next common rejection is that the claim must be submitted to another contractor. This may be a situation where the claim was submitted to WPS GHA and it should have gone to another MAC or another contractor. These are CMS contractors. There is a contractor directory out on CMS's website that will tell you state by state where to go to find that information. I could show that to you in just a little bit. Next one, here's another outdated acronym, Patient Insured HICN. It's now the MBI, Medicare Beneficiary Identifier, and name do not match. Those have to match. The name on the claim form has to match exactly to the name on the Medicare card. Sometimes people neglect to put the middle initial there when the middle initial is indeed on the Medicare card. You do need to include that information on the claim form as well. It needs to appear exactly as shown on the card. In addition to reasons for common rejections, I wanted to provide for you just as a list of those common rejections by code. This is something we can easily pull from the data that we look at, and this database that I used to pull the information was created by our data informatics team. It's a department we refer to at WPS as Insight. These are the folks that pull the data reports that we request or that CMS requires we pull and analyze to find those top or most common rejections and denials. We can do so, you know, by reason or by HCPCS and CPT code. So I thought it would be interesting to show you those most commonly rejected codes, either HCPCS or CPT codes. 69210 shows up there. Medicare covers only removal of impacted cerumen. Removal of non-impacted cerumen is captured in the office visit or E&M code typically billed with this service. This service is not covered when performed by an audiologist. So I wanted to let you know that's a commonly rejected claim. You'll see a few evaluation and management or E&M codes that appear here. 31231 is a nasal endoscopy. Botox is the J0585. Repair procedure 30520. That's a procedure of the nose. 95117 is allergen immunology. And then the 31575 is endoscopy. And typically what you'd want to do when you see something deny or a CPT code is you're going to want to look to see you know, for E&M service, of course, you could check the Evaluation and Management Services Guide. Remember that we allow only one initial service every 3 years for same specialty, same provider, same specialty, same group. Another thing you'd want to do here, you know, to find more information specific to codes is that you would want to use the lookup tool on our website to see if there is perhaps a coding and billing article that is the companion guide to a local coverage determination, so that you will know there's specific rules or guidelines or parameters for coverage for specific codes and such. Is there a local coverage determination that says WPS GHA will consider this service medically necessary, but only when it meets these requirements? So when you're looking at codes, I would look to that code lookup, and I will be showing you that in just a minute. All right, so here are the common denials by reason. Look at that. The first one and the fourth one. And I'm checking to see, you know, if there's any on my next slide, but there's not. Duplicate charges. Duplicate denials continue to be kind of a kick in our pants, folks. We have been educating for as long as I've been on the outreach and education team about avoiding duplicate denials. And we do have information on our website that speaks to this. We continue to receive thousands of duplicate claims every single day. And if you think about each one of those claims representing a cost to you, the provider, and to the Medicare program, that's a lot of money. So we want to do everything we can to avoid duplicate charges. So, you know, if you're using a billing service or within your office or clinic organization, if you automatically submit a claim in 30 days, if you haven't heard from Medicare or received the remittance advice for that service, stop doing that. Once submitted, keep in mind we do have payment floors. We have to hold the claim for so long before we can release payment. You know, those kind of things. Is it a service that we commonly develop on? All of those things play into this, but we really need to avoid those duplicate charges or duplicate claims. Let's look at the second reason listed here, and these are denials. Remember, they're denied claims, so you can't, sometimes you can fix it, resubmit it, but in many cases, what's going to happen is you're going to see rather on that remittance advice the notification that you can request an appeal. And if that's the case, you will need to take those steps to request an appeal. Remember, you can do that using self-service tools or self-service tool or our transactional portal, or there are other methods too. I gave you a resource earlier that provides for you a really great resource on our website that talks about what you need to do and where you need to send your request for an appeal. Payment included in another service received on, and that X001XX really represents a date, similar to the first reason listed there. This is just how it's printing out on the reports that are generated, but in this would have included a date. So you would look, look at other services that you billed to determine, is this service bundled into payment for another service that's received. 827 claims. There's duplicate charges, 668. Next one is pre and post-op care included in surgery. You may not bill the patient. This is the denial you will see for global surgery, those situations where the care that is being billed can't separately be billed because it's part of the global surgery payment. So there, of course, you would look to global surgery billing guidelines. CMS is a really great MLN or Medicare Learning Network booklet published that talks about what is and what's not included in the pre and post-op care. And I'll get to those resources in just a little bit. Here is more common denials by reason. Denied service or units of service are exceeded. This could be as it relates to the medically unlikely edits that are used during claim processing. If your units of service exceed the MUE value that CMS publishes out on their website, the service will be denied. More kind of bundling denials is represented in the next bullet. Separate payment not made for this service. Do not bill the patient. The next one is the claim must be sent to the employer group health plan first. So this is one that relates to the Medicare secondary payer program. In this situation, the claim has to be sent to the other plan first because Medicare is indeed the secondary payer. The next reason, the provider number is not valid for these Medicare services. There's some situations where a certain type of provider is not able to bill for certain services. This could be a reason for this type of denial, or maybe that provider number wasn't entered correctly. That would be another thing you'd want to check out to avoid this kind of denial. Next one, denied, can pay only one initial visit per specialty. All right, let's take a look at some common denials by code. There again, you can see mostly over in the left-hand column, those E&M services, evaluation and management. The 99024 is a global post-op visit, and it's used really for reporting services. So sometimes the fact that something's showing up as a common denial doesn't really mean that it's it is a denial. It could be those situations that don't pay because they are codes that represent reporting or something that's required for reporting purposes only. There's the 69210 again, the removal of impacted cerumen. I looked at that code because it appears on both the common rejections and the common denials list, and because when you registered and you gave some questions in advance, if they pertain to the program, I like to include the answers within my presentation or my actual speaking remarks. So someone asked, what's the most common rejections and denials for that service? And I looked that up because I can do that easily with this tool that Insight built for us. Payment is included in another service on the same day. Collection of fee-for-service during periods of managed care. So one of the top reasons to deny that particular code for your specialty was because the claim was submitted to WPS and it should have been submitted to the Part C plan or the Medicare Advantage plan. This code also denies a lot for duplicates. Also, it's denying because the claim has to be submitted to the employer group health plan first. So that relates to the Medicare secondary program. And finally, the last of the examples that I wanted to provide for you for this code is that the provider is not valid for this service. So it may be a situation where that the provider is billing for a service that they shouldn't be billing for. Now, I talked a lot about the data and what I looked at, what I pulled to present this for you. And of course, this was common rejections and denials that we're talking about today. We're not necessarily talking about documentation or other things that a claim can deny for, but I wanted to provide the data and speak specifically to those common rejections and denials in the hopes that this is going to help avoid those in the future for you. We can look at data in a number of ways. We can look at the state by reason, county by reason. We can pull the codes. We can even drill down to counties. So sometimes we do this when we do presentations for specific associations or societies that are elsewhere, or that are, let's say someone in northern Michigan invites us to come and talk. We can actually drill that data down and provide it to that particular group if they'd like that information. We can also look at trending. And what do I mean by trending? Here's an example. This is a data trend for denied services for your specialty for the time frame I told you about. Denied service or units of service are billed. This trending report shows us that for the current 3 months, 510 claim denials occurred. For the 3 months prior, 46 claim denials occurred. The difference in the number of claims is 464. The percentage of change is 1,009%. So for some reason, this trending shows that we received many more, or we had many more claim denials for this reason in this 3 months than we did the prior 3 months. So why is this important? And of course, the last bullet there is just kind of a visual when we're looking at these reports. It shows you increases or decreases. CMS expects that we, the MACs, are going to provide education to you to help you avoid these rejections and denials. So this really helps us know where we need to focus. What kind of education do we need to provide for you so that you can avoid these rejections and denials? And remember that these kind of claims, these rejected claims, denied claims, cost everybody money. So here then are resources that I told you I would include in this program today that was advertised. Claim form instructions are available on the CMS internet-only manuals, or in those manuals. Additionally, we have this crosswalk. I like to show the crosswalk to folks just so you can get a look at what I'm talking about here. If I go to the WPS website, I'm going to make this a little bigger for you. On the home page, over on this right side in the middle is quick links. This is where you can find links to our policies and other departments and such. And this is where you can find the link to our EDI department. This is our electronic data interchange. And of course, if you scroll down to the page, you can choose from WPS commercial insurance, TRICARE, or Medicare. We want to look at Medicare. And under Medicare are those guides and companion guides I talked about a little bit earlier when I talked about batch rejections, those companion guides that speak to the content of the reports that are generated to tell you why we rejected a batch of claims. But here, this CMS 1500 crosswalk, CMS 1500 to ANSI 837 5010 crosswalk is a crosswalk that tells you, for example, and I'm going to move down, so if my scrolling bothers you, look away just for a second. I'm going to find here. So for example, if in that CMS Internet Only manual, it says in item number 19, you have to put this information. This crosswalks that paper claim to an electronic claim. So it tells you if it goes in item 19 on the paper claim form, what information needs to be provided there, and where, what loop of the claim, and so on and so forth. It also tells you the status. So it tells you if it's required or a situational data element for your electronic claim. This might be important for those of you that have those claims that are denied or rejected because you don't have the claim dosage and the name of the drug and such. That should appear in item 19. However, on the electronic claim form, this is where you need to put it. You would need to come out to this cross-reference. Another thing I want to show you or look at quickly while I'm out on this page, so I don't have to come back to it, is the code lookup tool. This is where you can enter a code to see if a particular code is included within one of our local coverage determinations. I'm just going to try a code here, 30510. You would know that this code then wouldn't be included in an LCD or the LCD companion article. So this is a quick way you can go by HCPCS code or CPT code to see if that code appears within an LCD or the article lookup. And remember, when we search an LCD, it's going to search only the title, but for the article lookup, it will tell you whether that code appears in the article. Okay, so I mentioned I would show you that resource. Going to go back to the PowerPoint here and go through some more resources. This is a resource on our website for rejections, how to fix them. This is listed by remark codes. And what I'm talking about here are those RARCs, those CARCs that I talked about, those claim adjustment reason codes and such. So if you see a claim adjustment reason code on your remittance advice, go to this document. It will list the codes and it will tell you how to fix that claim. That would be a rejected claim. So you need to fix it, resubmit it. This slide shows the resource for denials, common claim denials, and we kind of group these by categories, those reason and remark codes for certain categories. So we have reason and remark codes for duplicate claims. We have reason and remark codes for denied claims for global surgery reasons or entitlement reasons or provider or contractor reasons, denials rather, that is. So this too would be a great resource for you for denied claims versus rejected claims. Our website, of course, has a lot of great resources. I showed you a couple of them earlier, or links to resources. Here is where you can find some great information about the Medicare payer situations. If your claim is denying because Medicare is the secondary payer, these are great, these question and answers. Additionally, we have some YouTube videos out on our YouTube channel that talks about Medicare secondary payer. Here is a link to our live events webpage. This is where you will find those education events that we are scheduling in the future. Encore Presentations webpage is the page where for about 90 days we keep the encore presentations, which is just another word for recordings of our live events. After today's presentation, the one we are doing now, or I'm doing now, we will have that recording available out on our Encore Presentations webpage, as well as out on our YouTube channel. The LCD and article lookup tool is the one I just showed you out on the WPS GHA website. This is the YouTube channel. There were a few rejections and denials that I talked about today that are really covered when you look at the YouTube channel. There's some great YouTube videos available for global surgery, also evaluation and management. So if you're looking for ways to avoid those denials, these are some great resources. Here are more WPS GHA resources. Some of the rejections that we had was that the modifier wasn't valid. We do have a modifiers webpage. I do want to show that to you as well. If you go to the Claims Topic Center, this is the homepage of our website. I went up here to the top to the Topic Center. Here are topic centers under claims. You could choose, your particular jurisdiction, and you'll have to accept the licensure agreement. If you scroll down, you will find modifier, and then go to the modifiers web page. And here then are a lot of really great resources listed by specific modifiers. So if you're having difficulty using a particular modifier or a service denied, I know one of the questions was what modifiers do I use for incarcerated beneficiaries? If you click on this link, it will take you to a resource on our website that talks about the resource you need, or the modifier you need to use when that beneficiary is in state or local custody. So some great information here. Other helpful, I'm doing Control F. I want to look for 79 real quick. This modifier 79 fact sheet talks about use of the 79 modifier. I know that there was some questions about that. Will claims billed with this modifier always initially deny or require appeal? And the answer to that is no. If the claim is submitted with enough evidence to warrant payment, when it's initially submitted, we can make payment for that service. However, the information would need to be submitted with the claim. Out on the WPS website, we have a resource, and this is listed in your resource section, I believe. Okay, it's a I can't type with, doesn't that always have ways to reduce? Okay, I'm looking for a resource, and I just happened to know the name of it, so I started typing it in. This resource here, Additional Documentation Ways to Reduce Your Burden, is a great resource that talks about the PWK segment of a claim. You can see that down here. A PWK segment of a claim, when you use it correctly and populate it at the time your claim is initially submitted, this alerts us that you have documentation. When you know that that claim has been accepted into our system, you can submit that additional documentation electronically. What happens then is when your claim is initially processed, we match the documentation up to the claim, and we can process that claim with your documentation. So this great resource tells you how to use that PWK segment. This is where you need to put what on that electronic claim. So that was a question in advance about how you can avoid those denials when the claim is initially denied. Submit that documentation initially with your claim. This tells you how to do it. So this is Additional Documentation Ways to Reduce Your Burden. And I think I asked Ellen to place that into the chat feature, actually. All right. Got about 10 minutes left here. Let's move on. Freedom of Information Act I've included here because I've heard from some folks that have attended my webinars. Well, how do I get the information for our clinic? Is it available top or common rejections and denials? The answer is yes, but you do need to request that, you need to use the Freedom of Information Act in order to do that. This is the link to do that. And it may it may involve a cost to the provider if you're requesting that type of information. Just want to give you that heads up. The next bullet says we want to partner with you. I mentioned earlier to you that we can pull data for specialty groups. We can drill down to county. We can drill state, even down to county. This is in those situations for any of you that might belong to an organization or society, you know, that holds conferences, and you want to request a WPS GHA speaker to come to your conference, a face-to-face conference. We could do these virtually as well. You know, to request a partnering situation or speaker, you could use this link to find more information. Okay. The MCD rather, is the national searchable depository of national and local coverage determinations. So let's say your claim denies because this service is not covered for this diagnosis, that type of rejection or denial rather. You would look to see if there is a national or local coverage determination. Remember, we have that lookup tool available on our website. If you're looking for information on how to use that tool or use the Medicare coverage database, CMS has published this great tool, how to use the coverage database. E&M Services Guide has a lot of great information as it pertains to evaluation and management. For those situations where bundling is happening or your claim is denying because it exceeds the number of units for this service, you would look to the Medicare National Correct Coding Initiative edits. This is where on CMS's webpage where you'll actually find links to the medically unlikely edits, those procedure to procedure coding edits. And of course, CMS has another booklet, how to use the NCCI tools available that will help you know how to use those edits and apply them for your claims. Other resources are, of course, the interactive voice response system. This is where you can check eligibility, status, find claim details. This is a tool, a self-service tool that's available 24 hours a day, 7 days a week, but there is limited functionality outside of normal business hours. For this, you would use voice or telephone keypad. We do have an IVR operating guide available that will help you use this tool. And here is information about our WPS GHA portal. I talked about this a few times today, that clerical error reopening process where you can fix your claims. You know, there's a list in that article, that resource that I gave you earlier that tells you you can fix these kind of omissions or clerical errors by using this process. You can use the portal to do that. You can check eligibility, claim status, claim details. And when you're looking at a claim line detail, let's say you're looking at a claim line for something that denied. If it denied due to another claim, as long as it's your claim, you'll be able to see an ICN for that particular claim. If your claim denied due to a policy that was applied or applicable, it will allow you to link directly to that policy. And what you're going to need to look for is a little blue button. It's blue button now. It might change in the future. It says more info. So if you're looking at claim details, you're using our portal to do that, click on that more info button. It's going to give you a lot of great information as it pertains to how to fix or avoid your rejected or denied claims. This tool too is available 24 hours a day, 7 days a week. There are instructions in our portal user manual. For those of you that don't know how to find that portal user manual, I've included the link. If you're out on any page of our website, I'm popping around here. This is the training center, of course, and upcoming events calendar. The portal user manual, here's where you log in if you're already registered, a registered user, but the user manual is available by clicking on this link right here. That's underneath the login box. All right. All right. Lots of great resources. All right. This brings us to questions, and I do want to look real quick at just a couple of those that were submitted in advance when you registered. One of the questions we received is we received denials when repair sizes are documented at the heading of the note, not described in the body of the note. Are there requirements? There's no of where the details need to be, and I don't know that there's any requirements of where sizes need to be, but I do want to let you know that it is expected that the patient's medical records are going to reflect the need for the care or the need for the services provided. And we would review documentation, determine if it adequately describes the medical necessity of those services rendered. So somewhere within those records, and we don't always say it's got to be here in the heading of the note or in the body of the note, but it needs to be, adequately describe what we did. And I guess my question is, if it's not in the body of the note, how do we know what you did? If you're just mentioning sizes elsewhere, we need to know what you did to fix those repairs or make those repairs. I talked about those common denials for the 69210 already. Remember that it needs to be reasonable and necessary. Payment is made only for removal of impacted cerumen. And I talked about the common reasons for denial. There were some questions about denials as it pertains to not otherwise classified codes. So I want to show you where you can find that information. If you're looking at the WPS, sorry about that, WPS website, we have an article on our website. Let's see, it's billing and describing not otherwise classified codes. Yeah, see it popped up for me there. I'm gonna click on it. This really great resource explains to you where you need to put the information to describe the NOC code that you reported on your claim, right here. NOC codes, for those of you, and we did have the denial that was related to this, for NOC drug and biological codes, this is the information you need to submit, and this is where you need to submit that. And remember, this speaks about item 19 of the CMS 1500 form. We've included the electronic fields, if you will, or where you need to put the information in the electronic claim. But if you're looking for advice for other types of services, where it goes on the electronic claim, remember that crosswalk that I showed you earlier, available out on our EDI webpage. Let me see. I've already talked about the 79 code, and I'm really kind of running out of time here. So what I'd like to do is let those of you know that if you do have questions, we will explain to you how you can submit those questions, and we'll get them answered for you. Any claim-specific questions, however, I'm not able to respond to. Those need to be handled in customer service where they have access to your claim information. Ellen and I and my other colleagues in provider outreach and education can't look at and view a claim denial. Our greatest compliment is when you recommend our education to others. Please consider doing this to help WPS GHA reach the greater provider community and reach our goal to assure current and effective education for all of those in our MAC jurisdiction. So on behalf of Ellen and myself and my teammates in provider outreach and education, I do want to thank you for your participation. We look forward to your survey comments, and we hope to have you join us for future events. You may now disconnect. Thanks, everyone.